Now we'd like to start the forum, the first program regarding AMR. We'd like to have a discussion, roundtable discussion about the AMR. We'd like to introduce the chairperson and also the speaker. Chairperson is going to be Dr. Mikamo from the Aichi Medical University, Graduate School of Medicine, and Satoshi Takahashi from Sapporo Medical University. And speaker is going to be by Dr. Norio Omagari, Japan Institute for Health Security. And second speaker is going to be Yoshiaki Gu, Institute of Science, Tokyo. And Alicia Demilchian, UK Health Security Agency. Please refer to the slide about the biography of each doctors. And regarding Dr. Alicia, she was planning to come to Japan. However, due to her plan change, she cannot come to Japan, and she's going to talk to us through video. Dr. Mikamo, Dr. Takahashi, please start the session. We'd like to start the roundtable discussion about the AMR. When we talk about AMR, all the people might know the AMRs, and WHO is paying close attention to AMR, and they have created and they have ordered each country to create the action plan. And in Japan, the second version action plan is now being executed. And we have two doctors to talk about the AMRs. What are the challenges and what are the solutions toward those issues? And we'd like to share those ideas. As introduced earlier, facilitator is going to be myself, Mikamo, and also the Takahashi from Sapporo University. Hope you enjoy the session. And first speaker is going to be from Dr. Omagari, Japan Institute for Health Security. Dr. Omagari, floor is yours. Dr. Mikamo, thank you very much for your introduction. I am Omagari from the Japan Institute for Health Security. I'd like to talk about AMR, and I would like to share the Japan and the Japan situation and also the AMR situation around the world. And first of all, Japan's situation. And when we compare against the global situation, Japan's AMR situation is a bit different, and it has a unique characteristics. And what is it? And the percentage of AMR of specific bacteria, and we have compared with other countries. And what are the characteristics of Japan? And the Staphylococcus aureus resistance is higher, very high compared to the other countries. And also the E. coli, the resistance against the E. coli, the third generation of cephalosporin, and also fluoroquinolone, the resistance percentage is much higher in Japan compared to the other countries. And the number of people who suffer deaths from these three bacteria is much higher compared to the other countries. So, and this is the unique situation of Japan. Here, in Japan, when we look at the burden from the AMR, and we are looking at the deaths from the drug resistance bacteria, and this is based on JANICE data. And there are 6 bacteria shown here, and MRSA on the top, and fluoroquinolone resistant E. coli, and also the third generation cephalosporin resistant E. coli, and the number of deaths from drug resistance bacteria. And since 2016, the number of deaths are growing, as you can see here. And MRSA and fluoroquinolone resistant E. coli, and aggregation is going to be 10,000, reducing the except for the overlap, and we are not seeing the improvement in the situation. So we're taking a lot of countermeasures, and why the situation doesn't change. So there are many factors that can be considered in Japan. The uniqueness of Japan, I think it might be suffered by other countries later, and it is coming from the aging society in Japan. So as this situation worsens, the number of deaths from these drug-resistant bacteria is going to remain pretty much the same for the time being. And at the same time, when we think about the drug-resistant bacteria, and it will increase when we use it unnecessary. And there are other reasons for the increase. And number one is that, like other infections, the drug-resistant bacteria are brought from overseas. And this is my patient. And he was working in the construction site in the East Asia countries, and the heavy industry materials fall from the building, and then he suffered the bone fracture, and he went through the surgery in the East Asian countries. However, he had to come back to Japan, and this is the Coxiella pneumonia sensitivity and numbers, and this is that he is infected by the colistin, and this is a drug-resistant bacteria. And internal medicine is not good enough to control his symptoms, and then he has to be amputated, and he was able to save his life after the amputation. And drug-resistant bacteria are imported from other countries, and carbapenem-resistant bacteria, and it spread in Japan after imported from other countries, and it is happening in Japan. So, and we are impacted by overseas countries, and then the bacteria are being imported from other countries, and that spread in Japan. And this is situation that we have to think. And then it is happening rapidly, and the microralia resistance and also the whooping cough is something that we have to consider. And this has been the shocking event for me. And another important issue is the VRE, and vancomycin resistance E. coli infection is increasing, and this is the number reported based on the infectious control law, and it is increasing rapidly from 2020, and the number of reported cases are increasing. So in 5-10 years, the overseas-based VRE are being brought into Japan, and then VRE is spreading from people to people in the region in Japan. So because of that, and in various regions in Japan, the VRE outbreak is happening, and the reason why this number of reported cases are increasing. And those people who are involved in the countermeasures, and this is something we have found. And of course, the measures in the hospital is very important. However, the countermeasures has to be executed in community and regional municipalities, and without that, it is very difficult to find the ultimate solution about the VER. And the problem is not only happening at the hospital, medical institution, but it is spreading and happening in the regional communities. So, and Japan needs to have the action plan against the AMR. And based on the decision of WHO, we have created the National Action Plan on antibacterial resistance. In 2016 was the first version, and 2023 and the second version has been issued. Based on that, we are executing the countermeasures against the AMRs. And there are 6 pillars, and I would like to share the current situation depending on per pillar. And the first is the education and training. And what are the challenges here? And the literacy of national citizens about AMR is continue to be low, and it is not. We are not seeing improvements, and we ask a question to the general public: is that antibiotics are effective for flu and cold? And that's the question. And the percentage of is blue. If it is high, we are seeing improvement. However, many people are still saying that this is right. And many people still think that antibiotics are effective for flu and cold, and situation is not improving. So that is the current situation we suffer.
医師の処方行動はいい
Because the prescription trend is going to go positive. So this is the survey conducted by the Infection Academic Society. So by having all the doctors had cooperated in order to complete this survey. And what we understood is that the rate of antimicrobial drugs prescribed during the cold-like system has been coming down. So this blue bar, the percentage, is coming up. This is a trend for these years. So what this means that if the cold-like symptom patient comes in to your clinic, and how many of the doctors will prescribe a cold was 20%, and this percentage is coming up. So it means that the antibiotics prescribed for this cold symptom patient is coming down. And this, so the guideline has been issued from the MHLW, and the premiums has been given to the doctors who has been prescribing less antibiotics. So this is the challenge and the trend in terms of education and awareness. So we haven't been seeing much improvements among the Japanese. And even though people have some necessary information, the number will not necessarily come down out. And for the physicians, changes in the behavior knowledge, and we have been seeing it improved. And also we have this surveillance. So we found that the prevention measures in clinic and hospitals and the data has been able to be aggregated. So we have a platform called GSphere, and by utilizing this, we were able to collect necessary data from the hospital and clinics. So that will be transmitted by electronic form, and we were able to make it informative in making into the visuals, which will reduce the time and effort of the person working in the field. And this is enabling people to have conduct surveillance and start discussion. And I believe that this is a positive trend. One more thing is that human, animal, food, environment, so related data in terms of AMR are being collected. And we have been seeing improvement coming on. And there are not many companies which could aggregate these data. So what we have to do from now on is to make the use of these data collected. So in terms of surveillance, we're starting to be able to collect data. So what we have to do further is to utilize that data. And so we have been seeing improvements in One Health approach. So human, animal, food, and environment. And the linkage has not been fully analyzed. And I think that will be done better in the future. And in terms of the appropriate use of the antimicrobial, the MHLW had issued a guidance. And based on this guidance, we have been providing education and trainings. And this is, I think, that giving a positive impact. And we have been seeing a revised version this time. The volume 4 came out, and this has increased in the dentistry. So the dentistry has been playing a lot of time, and we hope that the antibiotics will be less used in the dentistry setting. And this is a aware classification which is introduced in Japan. This was promoted by WHO, and UN says 70%. Japan tries to achieve 60%. So after using this classification, you can see this red proportion, the rate of access drugs, macrolide, and these are prescribed more than the other countries. So what we found from this data is that this aware classification cannot be directly used in Japan. And also, it will be difficult for us to make use of our classification. So what we discuss is that in the committee of MHLW, it was proposed that our classification to be changed specifically for Japanese use. So for the long-term perspective, including macrolide, fluoxetinolone, tetracycline, and ST combination, we consider this as a long-term. And by reflecting this Japanese condition, we hope that we can make this classification to be more fit to the Japanese situation. And I think I have already talked about the elderly situation in Japan. So maybe it's the same for the other countries, but in Japanese elderly population, we have been using more antibiotics compared to the other age group. So this is the trend of the oral antimicrobial use. And this is from 2018. So you can see the peak from the age range of 0 to 9 and also the age over 65. So I think you can understand that the parental microbials are used in this age group. So this is heavily used in the elderly population. Although this is a little bit challenging because the patient is admitted to the hospitals and they need this type of antimicrobial. Considering that, how we can use it much properly or how we can limit the use of antimicrobial, that is challenging and remains to be a big challenge. I personally feel that for the elderly, maybe we can increase the physical condition so that the admission rate to the hospital will be limited. So the prevention measure will be something that we can do in order to go over this challenge. So the challenge for the appropriate use is that the use of microbial and the volume of cells makes it difficult for us to assess what is happening in terms of treatment. So we have to focus more on the quality. And also, we have to revise the AWARE classification so that it will fit Japan. Also, other things might be done. So for the acne treatment in Japanese young population, maybe there's something that we can change. Also, we could change the people's behavior on the post-treatment. So what we can do, that will require more discussion. And individual data from patient is needed. However, under current Japanese situation, in clinical setting, it is difficult for us to collect information. Maybe we can utilize DX, digital transformation, but it could not done in one day. So how are we going to change? What kind of criteria we should do? It should utilize might need to go under discussion. Also, talking about the R&D of new drugs. So we have limited number of future drugs in the pipeline. It's not only for Japan, but also this is a global trend. And diagnostic agent is not much utilized in Japan and also in other countries. So in terms of diagnostic agent, the rapid testing, some of the infection disease could utilize these. However, the rest of the infection disease cannot access to this rapid testing. And also, some drug has difficulty in supply, and this has been a change based on changing the behavior of the people, and we have to prevent antibiotic to be supplied enough. So supply chain is something that we have to promote. Also, considering that the generic drug is limited in terms of the supply, maybe we could do something in order to promote the production. And talking about Japan, so we started to see a positive result. This is One Health survey. This is annual result for the annual survey. This is the data from last year. So we didn't see much changes for methadone resistant for years. Also, the fluoroquinolone resistance, it was on the rise for the past 10 years. However, we started to see decline from several years ago. I think this is what we would like to continue to follow the trend. So why this had happened? I think the use of the microbial might have been playing a positive role on this. So I think we have to keep on having a close watch. And this is the current situation in the global setting. So there's a disparity among the area. And the area which has issues in access of the medical resource is struggling a lot. And for the healthcare system in the low and mid income has a fragile Medicare system. And having MRA measurement will not be a priority in this kind of country. And they don't have enough budget, which will make it difficult for the government to promote the necessary measure. So E. coli, K. pneumoniae, the resistance is coming up. This is becoming a great threat in the world. And also Campylobacterium resistance, Actinobacter and K. pneumonia is also on the rise. And some part of Japan is also having a high rate. And this trend has been continuing for years. And also fluoroxine resistance is high in some disease. And also ceftriaxone resistance is low. However, we have to have a close watch. So, but I had an opportunity to listen about the Chinese and Vietnamese situation. And I learned that they have been promoting the preventative measure on top of the necessary measure for the elderly people. And we hope that we can take it as in a good trend. So thank you very much.
はい、大曲先生どうもありがとう。
Dr. Omagari, thank you very much indeed for your insightful presentation on AMR. And he has shared the global status and also the Japanese challenges as well. And we are planning to have the discussion later. So whenever you have, whatever the questions you have, you will be able to accommodate those questions later in the discussion part. Dr. Omagari, thank you very much. And we would like to move on to the next one title, which is the current status and initiatives in healthcare settings. And we invite the Dr. Yoshiaki Gu, and he is from the TCIDEA, and he's got the great insight into the antimicrobial resistance, and also he has been deploying the various kind of countermeasures. So, Dr. Gu, please. Thank you very much, Dr. Takahashi. And good afternoon. I am Gu from the TICDA. And following the Dr. Omagari, I'd like to just share my insights on the current status in the clinical practices and healthcare setting. And citing some of the examples in my hospital, and also, and then let me just share some of the clinical practices in other small and mid-sized hospitals as well. And as you can see, AMR, the antimicrobial resistance, and it doesn't seem prominent, but it is daily life in the clinical practice. You can see ESBL producing E. coli was detected in the urine of the cystitis patient. There was no underlying disease. Or maybe methicillin-resistant Staphylococcus aureus was detected in sputum, leading to isolation and preventive measures. And treatment of a hospital-acquired pneumonia caused by the multi-drug-resistant Pseudomonas aeruginosa proved difficult. Therefore, for us, it is really the painful challenges.
and also vancomycin-resistant enterococci (VRE) were detected in urine, and subsequent inpatient screening identified VR in 5 patients on the same ward. Means that it is an outbreak in the world. So VRE, as you know, here domestically is currently drawing attention because it is becoming more and more prevalent. And in the clinical settings and the hospitals, it is very simple. In order not to generate the antimicrobial resistant countermeasures, there are 2 things we need to do. One is to prevent the emergence, and the other one is to prevent the spread. And specifically speaking, how to prescribe the antimicrobial drug is very important. So you need to limit it to the necessary timing and as appropriately. And it is easy to say but than done because we need to see through the most appropriate timing and also the dose. So we have got a lot of clinical studies to identify the when necessary and how. And not to spread the drug-resistant antimicrobial. This is a kind of prevention measures, but as you can see, even if you prescribe appropriately, you would have the generation of the antimicrobial, as you see. But you shouldn't spread the drug resistance from there. So not to generate and also not to spread. These are the 2 important tandem wheels. And as you can see, and the doctors, the assessment and also the treatment will be very important as well. And as you see that we have got the various kind of expertise and specialists, and but not all of the specialists are updated with the antimicrobial resistance. So that's the reason why we do need the antimicrobial stewardship, so we say. And in terms of the management, it is about the infection control has been taking the initiative in this. We have got the ICT in the hospital, and with this multidisciplinary team, we are tackling with the spread and also the prevention of the spread and also the generation. And that's actually headed by the nurses mainly. And based upon that, we have the antimicrobial stewardship team. It has been set up in many other hospitals, you can see, since 2018, because it's been also subsidized by the actual reimbursement system. And the name of the team might be different depending upon the hospitals, but if your hospital has a certain scale, and it's been equipped. And in our hospital, AST or ASP, so we call antimicrobial stewardship program, is being deployed on the left-hand side. You can see this is actually the homepage citation from our hospital, and you can see on the right-hand side it's summed up. And as seen in the green characters, a clinical support in collaboration with the Division of Infectious Diseases, that's done. And also the red language says antimicrobial use management, post-prescription audits and feedbacks, and reporting system and approval system. Because after the prescription, now we are checking if it is really used properly, and also we have the appropriate utilization of microbial testing and results. So those are the initiatives we are taking on the AST. Another thing is the testing and the micro rounds of testing in order for the best assessment and diagnosis. So what is most important is to utilize this kind of microbiological testing, and that's actually covered in the AST activity in our hospital. And you see now we are teaching hospital, so you can see we have a lot of residents and also the students as well in a medical school in the hospital. And every day at 10 a.m. We are getting together at the testing lab, and that includes all the clinical physicians and also the lab techs and also the nurses and the pharmacists all gathering at 10 a.m. in the morning. And this is actually the opportunity to educate all the members and also to understand by the actual examples of patients. And also, as you can see, blood culture, including bacteremia patients, are included in the testing. So we are checking those bacteremia patients. And also, you can see inoculate the samples, including the spinal fluid. Those are also tested in the lab. And we need to check and identify the severe patients from the testing lab. And we are checking against the medical chart. And we identify the clinical treatment. And then we may identify the challenges. And in the case now, we are going to liaise with the infection internists together. And from time to time, and then we oversight. Let's say we have the antimicrobial, but sometimes the prescription drug may not be sufficient, so we are actually checking it, counter-checking. And you can see this is the actual microbial testing lab, so it is very easy to collaborate with the lab tech. And you can see the lab tech will be able to explain how to interpret it, and they are able to discuss the interpretation outcome together with the actual clinical physicians, so that we are having this opportunity to have this discussion together with all the members. And also from the clinical physician's point of view, they would request the additional testing depending upon the interpretation. Actually, infectious disease treatment and also diagnosis, that's very important to have the multidisciplinary team. So it's really the typical example of team medicine. And we've been taking a lot of initiatives, but thankfully, and I think we are seeing quite a lot of effects since 2015, and this covers 10 years. And you can see these different antimicrobials laid out. You can see when I was integrated in this hospital, and as you can see, there's a dotted line when I was employed, and then we reinforced the use of the optimum use. And you can see the red line is a carbapenem, most important drug. And then you can see that the use has become 1/3 of the peak. And another target is, as you can see, there is another drug is bipinacillin and terabactam. It is a gray line is hard to see, but compared to their peak time, it has become almost half of its prescription. So the use and the prescription of the antimicrobials are being suppressed, but we are to provide the optimum treatment for the patients. And we have seen the poor prognosis of the patients, and we see no incremental the antimicrobial growth. So we think it is very successful. And another thing is another pillar is the infection prevention measures. According to the medical text, you can see eliminating the source of infection, interrupting the transmission routes, enhancing the resistance in vulnerable individuals. These are the 3 pillars, as you can see. But what is most important in a clinical setting is to interrupt the transmission routes. And this is the standard precautions, and route-specific precautions should be thoroughly implemented. But as you can see, among those standard precautions, you can see the hand and feet and hand fingers. They have to be completely clean up, and as you can see, and sterilized. But that's got to be done. But that's not done thoroughly, even among the clinical practice. So that's most important. That's the reason why we do need the strategic approach. You can see, and then if there are the right place of those antiseptics or to be placed in the clinical ward, it is important. And also, even if you know that in your mind, if you cannot take action, your environment is not right. And also the training is needed to take the appropriate action. And also the measurement and assessment must be done in the environment, and then you must be able to have the feedback route to be able to report the inappropriate measurement or assessment. And where to assess is very difficult to decide, even among the specialists. And also you need to have the kind of posture in the clinical field, and to build the organizational culture to be able to cope with the situation.
And the hand sterilization, that's on the left bottom, and each room has this sterilization for hands. And 2.5 years, we needed to update the setup. So we have decided, which side of the door that all these equipment should be posted. And because there are the moving line on the nurse station side, the nurses move around. So that we have looked at the appropriate site and also the side of the door, because there are tall nurse and small nurse. So we had to identify the best height for putting these equipment on the wall and door steps, door side. And the apron and clubs and PP are often used. So, and there has not been consideration when the hospital was constructed. So we used our ingenuity to facilitate the on-site preparation. So they'll be able to know at what height they can find what equipment. And if there are any patient inside of the room who needs the infectious control, we put the magnet to notify others. And we try to create the organizational, the culture. And we have asked the head of the hospital and also the head of the nurse. And we have asked them to take a picture and then appear it in a poster. So we created this poster and just pasting poster on the wall, and it just becomes one of the landscape, and then it loses efficacy. So every 3 months, we're trying to change the poster on the wall. So this poster, it disappears and then it's no longer on the wall. However, that is the efforts that we're making. And this is Lego on the right. And our hospital, we are combined with the Tokyo Industrial University. We have become the institute called the Institute of Science Tokyo, and Tokyo Industrial University have the Lego club, and then we have created a student to create this symbol with hands. So let me talk about the small and medium-sized hospital. So this is the Janice data. The hospital more than and less than 200 beds. And when we clearly say that our AMR percentage is much higher and by 10% at small and medium, and E. coli resistance AMRs is going to be much higher in small and medium-sized hospitals. So there are many challenges that small and medium-sized hospitals are facing, and there are many reasons. But there are some researches and investigations, and due to chronic shortage of personnel and funds, investment and efforts in infection control have been put off. So there are expertise and many expertise in the big hospital, but that's not the case in the small medium hospital. And then there are not many lab rooms in the small hospital. And this is the Tokyo Metropolitan Hospital Infection Control Improvement Premium Calculation Status. And to support the national government to support the infections control, they have given the premium depending on the functions and the characteristic of the hospital. And there are many hospitals who are not enjoying this premium, and hospital lower than 200, so only 50% of the only 50% of the hospitals are gaining the premium. Of course, there are conditions to get this premium, but I think they think that just satisfied condition doesn't bring extra benefit and profit to the hospital, and infectious control at the small, medium-sized hospital. And there are many hospitals who are not getting the benefit from the national policy of providing the premium for having the infectious control measures. And this is the VRE outbreak in Aomori Prefecture. And there was a BRE outbreak in Aomori Prefecture. And there are many patients with positive BRE. And there are patients, the small bar, and that is the patient from small hospitals. And we do the screening, and there are many positive patients found at the large hospital, but there are many small hospitals who said that we're not going to do the screening for VRE. And there was the outbreak and spread of VRE patient in Aomori prefectures, but small, medium hospital and also the elderly nursing home will suffer the spread of the VRE. But a large hospital hospital can't invest into the countermeasures or the VRE control. However, the small and medium hospital could not have a leeway to invest into these infectious control. So the small, medium hospital and the regional expert has to work together. And this before pandemic, and this guidance has issued, and the municipalities and the small hospital has to consult to take on the measures. And for example, public health center can play as a hub in the region and connecting with the key hospital of the region. And it's very important. And then we have to make sure the HCPs are visible and the person in charge are visible from the every aspect of the region. And this is the program, 1-year program to support the small hospital in local cities. And this is found out. And the program to support the appropriate usage of the antibiotics. And then how should we do the surveillance? And what are the technical, we thought the technical stories of the antibiotics usage. And when I joined the program, it was found out that how can we find the issues? And they didn't have a good system for the decision making. So they didn't have a good teamwork, and then there are not effective communication happening across the team. So I think I found joining this program that the way organization is facilitated and structures itself is the problem. So in taking on the AMR countermeasures, and hand sanitization is important. It's easy to say. However, to promote in that importance of the hand sanitation, it is very important that they create the structure in the hospital to make sure that they do the hand sanitation. And this is 2019 data. And most antibiotics prescription are oral medication prescribed in outpatient clinic. This is a comparison between a clinic and AP, and the oral outpatients are the largest in terms of the volume of the antibiotics uses, and we have to pay attention to the hospital usage too. And here, like said earlier, this is the guide for the appropriate usage of the antibiotics, and this year the newest versions has issues on January 16th, and it focuses on talking about the outpatient care for adult and children for school age and older. And there are version 3 and version 4, there are no change to this flow. So when the patients claim the cold, we have to make sure the drug will be used appropriately according to this flow, and using this guide. And Dr. Omarigi just said that the usage situation of the antibiotics becoming better thanks to the guide, and we need to continue to improve. And there are better tools for diagnosis. So we have to make sure that our diagnoses are accurate so that the antibiotics is not going to be used inappropriately. However, 2023-24, there was an increase in the usage of the antibacterial drug, and maybe due to the COVID-19. However, the graph on the right bottom, and this is the antibiotics prescription for the acute upper airway tract infections, and then it has been lowering from 2020 to 22. However, it shows the slight increase in 2023-2024. So I think there has to happen something to improve and change this trend. And then we have done the online survey targeting clinical doctors, internal medicine, pediatrics, otolaryngology. And depending on the age and also the speciality, the way they think seems to be different. Well, huge difference, I actually feel. For example, pediatricians and AMR countermeasures is very important for the future. They say it. However, other department doctor doesn't say that. Doesn't think so. For example, when we talk about the WHO story, and then otolaryngologist doesn't respond well. So I think it's not good or bad. However, the response seems to be different, and also the utilization of the guide is different from department to department. And the doctor younger than 49 have a higher usage of this guide. So we have been doing the campaign to penetrate these ideas. However, depending on the speciality and also the age, we need to tailor-made the countermeasures. So this is the take-home messages, and this is the summary of what I just mentioned. Countermeasures against antimicrobial resistance have become a daily routine for medical institutions, and we need to have a good strategy. And the important area is that we need to show support to the small and medium-sized hospital, and we need to focus on how the team work can be facilitated at a hospital. And we need to further promote the appropriate usage of the antibiotics in outpatient care, and it is important to consider characteristics of medical department and age group of the doctors.
So, Dr. Gu, thank you very much for your presentation. I think preventing AMR is something, and also preventing the spread is one more thing which is crucial for us. And what you have been doing and the challenges, I think you had focus on that. So thank you very much for sharing that part. So next will be the presentation from Dr. Alicia Demerjan. But before going into her presentation, there's one information. So Dr. Alicia is in the presentation is in English. So for those who would like to use the Panagai, the Japanese translation, you can use the device so that you could start listening the Japanese version. Okay, so next will be the presentation from Dr. Alicia. Thank you. Hi everyone. So first of all, I would like to sincerely thank you for inviting me. Unfortunately, I have suffered a broken leg, and I am unable to travel to Japan, which I deeply regret. I am truly grateful for your kind invitation. Now, I would like to begin my presentation. Thank you very much for your attention and cooperation.
Good afternoon, everyone. I am sorry for not being able to join you in person as I broke my foot recently. I am Alicia Demerjan. I am a medical epidemiologist at the UK Health Security Agency and a pediatric infectious diseases doctor at the Evelina London Children's Hospital. I declare no conflict of interest. I would like to acknowledge the multiple people who have supported the work that is described in this presentation, and especially the ICDC Tokyo team for the invitation and for the very short notice translation of the slides. Sumimasen. I'd like to briefly introduce the national public health agencies of the United Kingdom. We are 4 countries, so there's 4 of us: Public Health Scotland, Public Health Agency in Northern Ireland, and Public Health Wales. I work at the UK Health Security Agency, which represent the work being done in England. Here is a summary of our goals and priorities at UKHSA. It is to reduce the impact of infectious diseases and antimicrobial resistance, as you will see at the center. But we also have several other goals, and especially achieving more equitable outcomes where we can. Like you in Japan, we have very strong partnerships with a lot of other people and a society response with industry, academia, and civil society. We followed the Global Action Plan, which was put together by WHO in 2016, and since then have designed the UK's 20-year vision for antimicrobial resistance, which was launched in 2019. But also we are now in our 2nd National Action Plan to confront antimicrobial resistance, and this timeframe is 2024 to 2029. There are 4 key priorities in this specific National Action Plan, and this is how I will structure the rest of my talk, talking about these 4 specific themes. I'd like to start with reducing the need for and the unintentional exposure to antimicrobials. We all know that this starts with infection prevention and management. We also all know that society relies on antibiotics to fix some broken systems, sometimes that rely on poor hygiene and poor patient care. And this results in a lot of unnecessary antibiotics, which will further contribute to antimicrobial resistance. In 1846, Ines Semmelweis, a Hungarian doctor, had found that women who were giving birth to children and being looked after were doctors had much higher mortality rates than the ones who are looked after by midwives. And from there on, we now know that hand hygiene is extremely important in terms of infection prevention and control. Our colleagues in the National Services Scotland have gone further and created a National Infection Prevention and Control Manual. This includes advice on how to have interventions for IPC in hospitals, but also on high consequence infectious diseases, so for national emergencies in terms of infections. We now have a 4-nation manual that describes these interventions. In England, this is another example going specifically about surgical site infection surveillance, and we see that the trusts who have adopted this surveillance programs in their hospital have found a reduced rate of infections. I'd like to remind everyone that vaccines are a very important part of infection prevention and control. The pneumococcal vaccine specifically is a great success story. In the UK, it was introduced in 2006, and then later the 13-valent in 2010. And not only did it decrease pneumococcal infections in young children, but also in the rest of society. We are now introducing the RSV vaccine in the UK, and I'm very curious to see how this will change our field for the years to come. Going now to public engagement and education. The Scottish Government has a list of resources that they have used for World Antimicrobial Awareness Week. We have leaflets, videos, and lots of examples that you can find on their websites and the websites of the 3 other nations. I include some examples from Europe, from the US, from France, and of course from Japan, which you have a fantastic campaign using manga characters. In the UK, we have launched several years ago a toolkit called eBug. So this is a list of tools that can be used for educators, for families, to teach children about infections and how to prevent them, how to wash their hands, including some games about how to understand how infections can spread from one person to another. We also support the Antibiotic Guardian campaign, where healthcare professionals and members of the public can pledge to be an antibiotic guardian, and we know that this is a very effective intervention that will predict positive behavior for infection prevention. These are some examples of our social media and our campaigns in the hospital where I work, the Evelina London Children's Hospital. This was a few years ago now, but as you will see, we have involved people from different disciplines, not only the infectious diseases doctors, a lot of the pediatricians, our nurses, our pharmacists, our medical director is over here, and some champions, for example, some doctors from other specialties, the respiratory doctors, the surgeons, and a wide list of disciplines. And I think that is really important to find these champions so that they can help us, especially in the hospital. I take that opportunity every year when I go around with these, and I'm not going to go into all the details of the study, but this is my opportunity to remind everyone that antibiotics are not harmless, and actually, especially for children who are very young, for them receiving it early in life might be associated with long-term outcomes, things like obesity, things like asthma, things like being overweight, having dermatitis. And I think that is something that we don't necessarily think about when antibiotics are prescribed, and we have to be more careful about it. This is another study that shows similar findings with a much larger database, and I think this is extremely important to keep in mind. Some other work that we have done with communications is the antibiotic campaign. So this is a giant pill where there are some videos that we have put on TikTok to also encourage young adults 18 to 34 years old to also engage in positive behaviors around antimicrobial resistance. Antibiotic has visited us in the office, and I hope that you will also find an antibiotic equivalent to come and see you when you work. One of my favorite ways to reach out to the wider public who may not have heard about AMR is through the arts, and specifically this is music. So this is a musical theatre that has gone through several countries in the world. They are now coming to London, and they have a chorus of healthcare professionals and scientists who will be singing with the professional cast to talk about penicillin, Alexander Fleming, who discovered penicillin, and the life of people with cancer who have infections that are difficult to treat. Talking now about strengthened surveillance, which is the bulk of the work that I do on a daily basis as my team leads on the surveillance of antimicrobial resistance and prescribing. On one hand, we have, like you, a reference laboratory where the local hospitals will send some isolates, especially with difficult resistance mechanisms, for more identification and for advice in general. There is also a research and development agenda for us. We spend a lot of time putting together the epidemiology, and like you, especially speaking to my colleague, Dr. Nobu Matsunaga, I know that you have very good reports that describe the epidemiology of resistant infections in Japan. This is our equivalent in England, and I invite you to look at it. This is the title of it. It's the S-Power report, and we have very nice infographics where we can perhaps talk more about what are the more important infections that we would like to prevent and what are the things that could be done to do so. We are also developing dashboards. So this UKHSA data dashboard is listed here, and it will have some more specifics where our colleagues, both from local hospitals, but also from the wider community, will be able to go and look at almost real-time information about specific infections in their area. We, of course, do a lot of work in outbreaks, specifically Candidiasis auris, which I know is an issue in many countries. This is one of our latest epidemic curves, and I'm very happy to discuss this more if people would like to get in touch with me by email. We also have some efforts that are not all year round, but once every 3 to 5 years. This specifically is a national point prevalence survey when we go around all the hospitals in England and in the UK who would like to participate. And in our last round in 2013, we had 293 hospital sites who participated. That was more than 44,000 participants across all ages. And we look at the healthcare associated infections, the antimicrobial use, and the stewardship that they have in those areas. And that helps us inform what is happening in the country about infection prevention and control and stewardship. One thing that I find really interesting when we do those point prevalence surveys is to see how variable practice is from one place to another. So different hospitals might be looking at the same national guidelines, but they might be implementing them differently. And that has forced me to think a little bit about behavior and what influences our behavior. And I think Hofstede's cultural dimensions theory is really interesting in infections and antibiotic prescribing. And specifically, I would like you to draw your attention to the power distance, the first one, and the uncertainty avoidance index. And thinking about these, this is, for example, the power distance is a type of thinking when people like to have an egalitarian community, be it a country or a hospital or even a team within a hospital or a workplace, where everyone has the same say and the same right, versus another team who really likes hierarchy. They like that there is one person who takes the decision and other people follow, and that has to be clear in people's minds. And so these two different teams from a different perspectives may not apply guidelines in the same way because they do not necessarily perceive them the same way. And I think when we write guidelines and when we design interventions, we have to keep that in mind. Similarly, for uncertainty avoidance, on one side of the spectrum, you have people who are comfortable with uncertainty and some others who are not comfortable with that. And when we think about, for example, a patient coming in, let's say a child coming to a clinic with a cough and a fever, and it's very likely that this child will have a viral infection, does not need antibiotics, but some prescribers, some doctors, some clinicians will be less comfortable with the uncertainty that it's definitely not a bacterial infection and will be prescribing antibiotics more than necessary. So we have to help all the people who are on the spectrum with the tools that are needed for them to overcome these different dimensions that are influencing their behavior. This is some information that, again, I'm not going to go into too much detail about, but just to say that there are data that show that actually these different dimensions have very important implications on what we find, especially for antibiotic use, as well as perioperative prophylaxis for more than 24 hours. So this is antibiotic prescribing for a longer time than what we all think is necessary. Moving on to the next theme, which is optimizing the use of antimicrobial, I'd like to talk about antimicrobial stewardship and disposal. Our colleagues from Northern Ireland have shared this optimizing use of antimicrobials dashboard. This is a very nice tool, which again, I know that you have a similar one to be able to speak with the local hospitals. You go and you tell them, oh, I've seen that you prescribe this much. The hospital next to you prescribes differently, maybe more, maybe less. Can we sit down and speak to each other and better understand why there are differences there? And very often, this is where I see some of the most productive conversations will start and some of the more effective interventions, because they, from the beginning, involve the people who are on the ground doing the work. Some more work from our colleagues in Northern Ireland. This is Pharmacy First, which has been a very successful system where patients no longer need to go see the doctor in a clinic appointment for some of the considered simple diagnoses. For example, this is UTI, urinary tract infection, but there's also pharyngitis or sore throat and otitis media. And these interventions have shown to still result in very good prescribing without overly prescribing antibiotics. Public Health Wales have also shared an example here. This is about respiratory tract infection duration in primary care. I am sure you also have similar examples in Japan, where some prescribers like to give a very long course of antibiotics, while we know that 5 days and sometimes even 3 days are enough for a community-associated pneumonia. So these are some really nice efforts that show that has been more prescriptions of the correct duration, which is 5 days and not more than that, following the efforts of our Public Health Wales colleagues. There are some other tools that have been created. Here, I'd like to mention Rebecca Ottel's work. She has created a very nice tool to switch from IV to oral antibiotics in the hospital. So a list of questions that people look at can, for example, this child swallow antibiotics? Do they no longer have a fever, or have they clinically improved? And when you look at the checks, if most of the checks are yes, this is a tool that supports the decision to switch from intravenous to oral antibiotics, which we know is another low-hanging fruit in antimicrobial prescribing. I am very privileged to lead a group called the UK Pediatric Antimicrobial Stewardship Network, and we have some fantastic guidelines that help us harmonize the use of antibiotics, specifically in pediatrics, where there is not necessarily a lot of information out there. This is the website for our group. The registration is free. If you would like to join us, the website is listed here. The next theme is investing in innovation, supply, and access. Innovation and influence is a theme that I think both Japan and the UK can have a very strong role globally. We know that to have high impact treatments, we require a whole pipeline. And for antibiotics, this costs a lot of money, a lot of time, and we need a lot of workforce and people to get together to be doing this incredible work. Sadly, antimicrobial discovery suffers from a common pool problem because we see that there's insufficient funding, insufficient academic research, clinical research, and limited markets. And so the production is slow. And on the other hand, resistance itself is increasing because of the overuse of treatments that we spoke about, because of the inappropriate use, environment pollution, and inappropriate use in agriculture. So all this means that there are less antibiotic options that we absolutely need to keep medicine working the way it is at the moment. Without antibiotics, we cannot do surgeries, we cannot give cancer treatment. So they are absolutely essentials. The UK has been a pioneer in the NHS and NICE subscription system for new antibiotics, and I am very aware that Japan is doing a similar effort, and I'm very thankful for this. This is a system, as you know, where pharmaceutical companies are compensated for bringing a new antimicrobial to the market, but not necessarily linking this to their sales. So we are not encouraging them to sell more antibiotics. The UK is only 3% of the global market, so we absolutely need other countries to get together with us so that we can together put a good pull incentives for pharmaceutical companies to think that this is a good deal. These are some of the criteria that we use to basically award these subscription systems to antibiotics. I am privileged to be the vice chair for the panel who evaluates these antibiotics, and these are some of the criteria that we judge. Approximately once every month, we review a lot of this information and we put it together against these criteria. I am also very privileged to have received the Dame Sally Davies Fellowship in AMR policy, and we have a counterpart. This is a collaboration with Japan. So this is the Mr. Yasuhisa Shiozaki Fellowship, and my colleague, Dr. Nobu Matsunaga, is the fellow who is a counterpart from Japan. And so together we have put this report that has recommendations for the UK government, and I look forward to doing more work in this space. The last theme is being a good global partner and AMR diplomacy. This is, again, a very important theme. Some of the UKHSA international collaborations are listed here. Like the rest of the presentation, it is impossible to show all the work that is being done in such a short time, but we have helped the launch of the Caribbean Antimicrobial Resistance Alliance project, CARA. We have trained Fleming Fund fellows who have come from African countries in some exchange work and also in some capacity building work. We have contributed through the years to WHO consultations, connected through WHO collaborating centers, and contributing to a lot of other work that is being done globally in AMR. We are exceptionally lucky to have the advocacy of Dame Sally Davies to support AMR in the UK and internationally. She is our special envoy for AMR. She is extremely busy, as you know, talking about all the good things that can be done and doing all these things to galvanize the efforts internationally to work together to confront AMR. This is her busy schedule, and we are very grateful for her work. I will leave you with this reflection which resonates a lot to me. The greatest challenge in antimicrobial resistance is the natural resistance of humans to change. In the end, if we want to change things, it's not only knowledge, it's not only rules that will help people. We have to find a way to influence people and influence their behavior. And that is the most difficult thing to do. I would appreciate any kind of insights that you have on this. On that note, I do think, as we mentioned earlier about the Hofstadter's principle, that different behaviors are done differently and are accepted differently in different cultures. And this is a bit of a fun tool that compares countries with those Hofstadter's dimensions there. And for example, I've put Japan and the United Kingdom there. And I noticed, for example, that uncertainty avoidance is one of the criteria where there is the most difference. So I invite you to reflect on how you think we can influence behavior in a way that is acceptable to our local communities, but at the same time we can put together globally to confront antimicrobial resistance. Apologies, my slides are no longer moving forward. Here we go. My final reflections are to say that it is important to implement strategies informed by behavioral insights and again work with cognitive scientists, behavioral scientists, health economists, anthropologists. So there's lots of different disciplines that will be really helpful to have input from to be able to do this work in AMR. Together, we can slow the spread of AMR. It is not impossible. It is something that we can change. It doesn't have to stay this way. There are opportunities to strengthen collaboration and communication between clinicians, public health workers, industry, policymakers, and the public. And this can be done globally. And I look forward to doing more of this together. Arigatou gozaimasu.
はい、それではですね、アリシア先生の。
Dr.
今日はですね、アリシア先生。
Dr. Alicia, thank you very much for your presentation. Since Dr. Alicia is not here today, so this was a recorded presentation, but if you have any questions, we won't be able to respond to your questions on behalf of Dr. Alicia. So could you please submit your question to the Tokyo ICDC Forum Secretariat, and they will be able to identify the responses from Dr. Alicia. So now from here onward, I would like to invite Dr. Omagari, Dr. Gu, and myself and Dr. Takahashi together for the discussion. And we'd like to open the floor for that purpose. In the first place, the floor doctors, and do you have any question to all those speakers here today? If you have any, please proactively raise your hand. And also those participants on the web, you can submit your question through the web. Then we are able to read those questions on behalf of you.
Question from the floor. Please use microphone. I am Saka from Tohoku University. Omagari Sensei, Dr. Gu, Dr. Omagari, thank you very much. And you are working very hard at the hospital, but that's not, I think we're at the juncture that that's not good enough to find solution to AMR. And number of beds, number of hospitals are so large and high, and then 30% of the patients are receiving the care at home. And I was working with Dr. Gu about that. And home care is going to be advanced and increased, and even at the acute stage, the patient may receive the treatment at home. And in case vectoridaxon once a day, it can be used freely. So if that is the case, even we work very hard at the hospital, I think we need the appropriate response in the community, and the palliative care services provided in the community, and the rehabilitation services being provided in the community at patient home. So we need to change the system itself. So when we think that, what UK said is that fundamentally, they created the guideline that antibiotics should not be used, and then there was a dramatic decrease in the use of the antibiotics, and there has been the increase in the number of infectious diseases. So they have adjusted the guideline, and how many dentists and doctors are using antibiotics. So they make the usage of the antibiotics visible. In Singapore, by hospital, they have the data by hospital. So by making the data visible, the system can be created and system itself can be improved. Without doing so, and I think it is very difficult to notice the usage of the antibiotics. And I'd like to hear your opinions. Dr. Omagari, please. Thank you very much for your question. Yes, making it visible is very important as a first step. JSIF clinics are now opened. So at the clinic, we can capture the MRS data and also the data, and I think it is 5% utilization ratio. So we have a clinic, but the system has initiated, fortunately, and home care. Well, I think the guideline is talking about how the care should be provided at the home, and it is very important to tap on it. But what kind of system should be developed? And there's no discussion, and nothing has started, and no system has been established in that sense. But the things that is used at the OSS, that we use the claims data file, right? Just like we use the claims data file, we may be able to capture the situation at the home care services. And more than that, the issues are here. And JACE versions are a problem, but well, I should not say temporarily. However, there are many indexes being involved, and indexes are visible. However, in Japan, which is the most important factor to change the prescription behavior, what are the best indexes? There's no discussion around it. And the research to look at the correlation, nothing's there. So at home care arena, almost there is no data, no discussion, and we need to proceed with such research. And if we could do just like what you say, we may be able to improve the situation. Dr. Gu, please. In home care, the service level is going up, and in home care, and how the infectious disease treatments are being provided, and we don't know how those are happening. And in my team, we are trying to start the research to look at the infectious disease treatment at home care. So maybe there are cases that the specific antibiotics are being used highly, and I can know it based on my gut feeling. However, how should we make it visible? And that's very important, but we don't know. And at home care, regarding home care services, and with the medical fee revisions and how much it is going to be reflected, and there are mixed changes regarding the home care field. So I think the challenges has been described by Dr. Omagari. So I don't say it again. However, the infectious disease specialist, what kind of how they think about the most appropriate for the home care infectious disease treatment. So there is still a distance. There are we don't know how the infectious control specialists are thinking about the home care. And the response in the community, I think patients are seamlessly shifting. Well, after they are hospitalized, they are going back to outpatient, or they are going to receive treatment at home, or they are going to go to the elderly nursery home. And there seems to be the wall, and the thing seems to be silo, working in silo. And based on examples, and municipalities and public health centers are working hard to remove those walls between institutions, and that is what I felt listening to what you just said. Thank you very much. That was not the answer, but it was how I felt. And thank you very much, Dr. Osawa. Dr. Kunishima, please. I am Kunishima. Thank you very much for a wonderful lecture. Earlier, the Dr. Zenmero-Weiss said that hand wash is very important. When we think about the infectious diseases, prognosis is very important. Like you said, it applies to vaccine, how the vaccination should be proceeded going forward. That's something we have to think. In Japan, influenza, COVID-19, and that we are Japan is the country that number of vaccinations very loud, and the antibiotics usage can be lower if the pneumococcal diseases are going to be lower. But we don't know the good data about the accurate data about the influenza vaccination ratio and volume. So I think promotion of the vaccination might be important, and by setting a target of the vaccination. What do you think of the targeting? Setting a target for vaccination. I think it is about the infectious prevention. So, Dr. Gu, can you answer the question? Yes. Vaccine is very important, and I totally agree with you. I am with you. And especially when we think about the countermeasure against AMR, like Dr. Omagari said earlier, that we have to think about elderly, and that is very important patient pool. And we have a good series of vaccine that can be used for older patients, older population. So when we become older, they think that influenza vaccine is good enough, but there are more vaccination becoming available for elderly population. So we need to promote the usage of vaccination. And then, do we have an answer? Do we have a good solution? No. However, to increase the vaccination ratio, one factor is cost. And second is that we have to make sure the patient thinks vaccination is important for their health. So in COVID-19, and the vaccination ratio was very high when the patient can get the coupon for the COVID-19 vaccination. So they have to have the awareness that I'm the one who has to be in charge of my health. So I think the one thing is that municipality can make appeal to the public, but public awareness has to be improved at the same time. And the third, we have to think about inpatient, hospitalized patient, and there are many inpatient hospitalized patient who needs vaccination. So we have been telling patient at random. However, if we can have a system to recommend vaccination to patient in need, that would be very efficient. So I think that might relate to the data management system of the hospital. So the way might be different from hospital, but multiple hospitals can work together to improve the awareness in the community. And if we can make appeal to the specific population who needs vaccination, that might be a very effective way. So we would like to work together to improve the vaccination ratio.
Thank you very much. So as Dr. Alicia said about the vaccination, Dr. Omagari has said that the resistance is the one issue that we have. And the vaccination, if the injection rate is higher, then maybe the historical pandemic didn't occur. So there's a speculation. Some people are talking about this speculation. So in order to manage this AMR, maybe vaccination is one key to solve that challenge. Okay, thank you very much. So in the remaining time, I would like to have me and Dr. Takahashi to give out a question to each of the presenters. So starting for me. So Dr. Omagari. So I think the Japanese population is aging. We have this as a social issue. And we are entering a extremely aging society. So we have to do something on that. And Dr. Osaka has just said that in this situation, there is something that we can do better. So reflecting myself, I generally think that the treatment in the final moment and extending the lives using equipment, maybe we should not use that proactively. But in the ICU setting, many doctors said that the antimicrobial should be given to patient in that stage. I think you often hear something like that. So I think the microbial in the external phase is something that we can do better. And is there anything that you have in mind in order to overcome this issue? Yes, thank you very much. I'm completely aligned. I have the same concern on that for the end-stage treatment. So in the end stage, what kind of antibiotic has been used? Unfortunately, we don't have that information or data yet. But reflecting, I think that many doctors have been prescribing this in volumes. So I personally feel that, so I was in the cancer center, and that experience has been influencing my behavior a lot. And considering the colleagues in cancer center, we had a lot of time to discuss each other. And we often say that for the patient who doesn't have a lot of remaining time, people were agree that antibiotics should not be used proactively. It's going to cause a bluff, and also the respiratory situation will get worsened. So we don't know how much positive side antibiotic will have. So what I think is that we started to have a different way of approaching because we don't know whether antibiotic has a benefit. And I think there was a theory to support that. So I think we have to focus more on the negative side in terms of the end-stage patient. And I hope that their family, their loved one, will understand that, and I hope that will become a benefit for the patient itself. Okay, thank you very much. So as Dr. Alicia said, so she said that the challenge for AMR is to change the mindset of us and the people. So I think it's a first step, and what we're going to do to fight that challenge. I think we have to improve the current perception for the end-stage patient and to come up with a good proposal. And Dr. Takashi, do you have something to say? Yes, this is a question to Dr. Gu. In your presentation, I think you mentioned about the infectious management team, and you said that how the organization work is one thing that we have to consider. And so I got an impression that the current condition from hospital to hospital differs quite a lot. So some hospital has been having a AMR measure, and only part of the hospitals are getting the premiums that the government provides. So is it because of the requirement? Is the requirement of the premium not matching with the current situation? Or is that whether the HCP does not have necessary understanding? I think we can approach for many directions. So in terms of improvement, what do you think we should do, to come around to this challenge? Thank you very much for the question. Yes, I consider this as very challenging. I myself have been involved in small or mid-sized hospital, and through the discussion, I have an impression that from the premiums perspective, the manager of the hospital will look at the requirement and the cost, and they try to balance the cost. So if the size of the hospital is small, it seems to be challenging for them. So they have to have dedicated personnel to fight with the infection, and also those personnel have to join the relevant committee. And some of the hospital has been currently struggling to hire nurses. So capturing additional talent is more challenging. So I think we have to have some way to make the head of the hospital to start feeling using the premium. Okay, so by using this premium, so without doing that, I think you cannot fulfill the necessary infection measure, right? Yes, that's right. So the larger hospital to look after the small and mid-sized hospital is how we manage. But it's not working properly. So currently, the public health officer has been intervening here. However, we haven't been seeing a success yet. Okay, yes, I also understand that public health intervention is needed. Okay, thank you very much. So I think we are approaching to the initial approach at time. So we would like to close the first session of antimicrobial resistance. I know that you, the participant, might have a lot of questions that you would like to ask. If you have, then please reach out to two of the presenters to ask some questions. So today, Dr. Omakari, Dr. Gu, and Dr. Alicia, thank you very much for your presentation. So we would like to close this first session. Thank you.
Mikamo Sensei, Takahashi Sensei.
Mikamo, Dr. Sensei, the Omakari Sensei, Go Sensei, Takahashi Sensei, thank you very much indeed for your contribution to the discussion part. And with that, we'd like to complete this round table 1.